So I'm going to try to go through an overview of what we do for regionally metastatic melanoma, and then if you guys have questions afterwards, I'll pass the microphone out there. Basically, when we look at a patient with regionally metastatic melanoma, we have to look at the patient through multiple aspects. The patient will get a therapy, but it really depends on the goal of our therapy. Disease control, are we trying to palliate symptoms in conjunction with other therapies? Are we trying to go for disease cure? We have to look at the anticipated side effects of therapy. The burden of disease, how much disease does the patient have? Do they have a little disease? Do they have a lot of disease? Is the disease rapidly expanding, or is the disease slowly progressing? Did the patient receive previous therapies? Does the patient have regionally metastatic disease as well as systemic disease? More disease like in the lungs, liver, and bones. Patient characteristics. Some patients are too sick for systemic therapy. Some patients have hypersensitivities to certain therapies and can't get certain therapies. And then we have to also think about, as a group and with the patient together, we think about sequencing of therapies. Do we give regional therapies before systemic therapies? Do we give systemic before regional therapies, and vice versa? So in-transit metastases is a regionally metastatic spread of melanoma between the primary tumor and the draining regional nodal basin. So these two patients had melanomas on their lower legs, and they pop up with all these in-transit metastases. As you can see here, these are all little melanoma metastases between their primary tumor and the groin regional nodal basin. So it's a spectrum of disease that's pretty difficult to treat. If we can resect it, if you have one or two in-transit or regionally metastatic lymph nodes or nodules, we're gonna go ahead and resect them. Immunotherapy, which I think you're gonna hear more about later, is also an option. Systemic immunotherapies are very new and they're very powerful in the treatment of melanoma. Targeted therapy, same thing. If you have certain mutations in your melanoma and we can give you a pill, that's also an option. Intralesional injections is another way of treating regionally metastatic melanoma, and that's with injections directly into the metastatic melanoma. Not a systemic therapy, but into the tumors itself. Radiation, participation on clinical trials, limb perfusion and limb infusion, ways of isolating an extremity and perfusing that extremity with high-dose chemotherapy. Obviously, chemotherapy has fallen out of favor with the treatment of melanoma with all these new and exciting and powerful treatments. And lastly, for these patients, amputation is an extreme last resort and very rarely ever performed. So I'm going to quickly touch upon some regional perfusions, and I think we're going to talk about them a little bit later as well. Isolated limb infusion is a way of minimally invasively isolating the extremity with a tourniquet. And you can see here there's a tourniquet on the patient's affected extremity. Catheters have been placed in the artery and vein in the other extremity. These catheters come and they're placed in the artery and vein in the extremity that's affected with the metastatic melanoma. Then we blow up this tourniquet and we perfuse heated chemotherapy only in the leg, because the tourniquet prevents that chemotherapy from going anywhere else. These catheters are percutaneously introduced. We circulate that heated chemotherapy for 30 minutes with the tourniquet up. Then we wash out all the chemotherapy and release the tourniquet. And the benefits of isolated limb infusion is that we can get 10-fold or higher concentration of chemotherapy right at the metastatic melanoma. And the tourniquet prevents any chemotherapy from going systemically, so there's minimal to no side effects systemically. And you can see here, this is kind of a picture of how the setup looks in the operating room. This patient has not a pneumatic tourniquet, but an Esmark tourniquet. It's like a big rubber band cutting off the circulation. The catheters have already been placed in the other extremity, and they're fed up and around into the artery and vein in the affected extremity. You can see all these little in-transit metastases in this patient's leg. So we're perfusing from about here downwards. And this allows us, again, to get that high-dose chemotherapy, heated chemotherapy into the patient's leg with very good results. Initially, we presented we published our Moffitt experience a few years ago, and you can see here we have about a 70% overall response rate, with almost a third of patients having a complete response, meaning all their disease in that field of perfusion has gone away. Sometimes it goes away for a long time, other times it can come back, but at least there is an initial complete response. About another third of patients have a partial response, where some of the lesions go away, but not all of them. And those are patients that we can then go back and we can resect the remaining lesions, or maybe we can inject something into the remaining lesions. And this is what I meant on one of my first slides by sequencing of therapies and combining therapies. Limb infusion is the minimally invasive way of performing heated chemotherapy to the extremity. Then there's also limb perfusion here, which is a maximally invasive, open way of dissecting out the vessels, isolating the vessels, and perfusing the limb with heated chemotherapy. Here at Moffitt, we do the overwhelming vast majority of the time we're going to do limb infusion and keep on with that minimally invasive way, and it also has much less local and regional side effects. Another way of looking at treating patients with metastatic regional melanoma is to inject these lesions directly. So all those lesions you saw in those first few slides, we can actually inject with different compounds. These are a couple of the compounds that are available right now for injection or ablation of regional metastatic melanoma. BCG is used for tuberculosis. We can inject that right into the melanoma, and it's been shown to help melanoma Intransit metastases regress. IL-2 is an interleukin agent, and it helps boost the immune system into those lesions. TVEC, or Imlygic, was just approved last month or the month before. It's a herpes simplex virus that we can inject directly into the lesions. I'm going to talk more about that. PV10 is a type of dye that's used for ophthalmology exams and liver function studies. Again, that's another compound that's been shown if we inject it directly into the melanoma, it'll help the melanomas go away. Electrochemotherapy is a way of providing electrical impulses into the actual melanoma metastasis while you give either intralesional or systemic type of chemotherapy, and it allows the cells of the melanoma to open up, and the chemotherapy goes into those cells and it ablates the melanoma. And topical diphencyprone is a cream that has been shown to be placed on melanoma and also causes melanoma regression. So here we're going to start with topical diphencyprone. This has been, DPCP as it's known, is used for alopecia or hair loss. It's a known drug here in the United States. It's also used for treatment of metastatic melanoma in Europe and Australia, and hopefully here at Moffitt soon. You can see here this patient had a scalp full of regionally metastatic melanoma, and after DPCP was placed on it, that melanoma has largely gone away. There's been reports that this has worked in up to 50% of selected patients, and obviously has very minimal systemic side effects, but local side effects are blistering and irritation. Electrochemotherapy or electroporation, as I mentioned before, is the use of short and intense electrical pulses that increase permeability of that cell membrane. It allows the chemotherapy to come into the cell, and you combine that with a cytotoxic agent such as bleomycin, which can be given either systemically or locally right into the cell. And it allows these melanomas to take up the chemotherapy, and has been shown in a very large European trial to have an overall response rate of 85% and a complete response rate of the melanomas that were actually treated of almost 75%. That means each of these melanoma metastases that are ablated with the electroporation, 75% of the time would go away. One of the side effects of this is obviously we're performing electrical impulses. It's done under either sedation or general anesthesia. It can be painful, and there's no bystander effect, and we're going to talk about bystander effect in a second. And you can see here some of the electroporation probes. They're needle-based probes that are stuck directly into the tumors. You can understand why that might be slightly painful. Intralesional injections. An injection of the agent directly into the tumor. The advantages again here, and with most of these regional therapies, are we use an extremely high concentration of the agent right at the tumor. It has limited morbidity, so the side effects are directly where we inject them. There's virtually no systemic toxicity, so the patients really don't have these systemic side effects of other types of therapies. The disadvantages, again, it can be somewhat painful, and there's frequent visits because you don't just inject these lesions once, you have to inject them every other week until they go away. Dr. Sarnak, who's giving a talk later on in the morning, is spearheading our PV10 program here at Moffitt. And again, PV10 is this rose Bengal dye that's been used in liver function studies and ophthalmology exams for decades. And we've seen that if you inject it, as you can see here, into the melanoma, it causes cell death directly, as well as it releases the antigens for the melanoma cells. Your body picks up those antigens as foreign, creates T-cell activation and antibodies, and then you can potentially see bystander tumor destruction, meaning we inject lesion A, lesion B hasn't been injected, but it does go away. So that's an advantage of PV10 intralesional therapy. There's a phase 3 trial that's currently underway, but the phase 2 trial was very promising, where it showed almost 50% of the patients who were injected had a response rate, and almost a quarter of the patients had a complete response. So it's not for everybody, but it's for patients that, 1, might not have other options, 2, might not want systemic therapy, 3, might have limited disease, and we can try PV10 without burning any bridges before we do systemic therapy. So there are a lot of advantages to intralesional therapy. I'm going to show you a couple of examples. Here you can see before this patient was treated, there's multiple Intransit metastases. After the patient is treated, this rose Bengal dye gives this bright pink type coloration where we've injected. About 4 weeks later, you can see the lesions have ulcerated and a year later, all the lesions are gone. So it's a very powerful therapy, and definitely when used in the correct and selected patients, has a great advantage to the patient. Same thing here. You go from pre-treatment to that bright pink type post-treatment picture, then ulceration of all the lesions. 6 months later, everything's gone. This interesting photograph here, they're highlighting B1, which is a bystander lesion. That lesion was not directly injected, but you can see is gone 6 months later. So it does have a bystander effect. It releases those antigens, your body picks up the antigens as foreign, they create antibodies, and it has this systemic immune type effect. And again, similar type picture where the lesions are injected and 18 weeks later are largely gone. Here's an example of the bystander effect that you can see. So obviously we're not injecting, this is a picture of a CT scan and a lesion in the lung. We're not injecting PV10 directly into the lung lesions, but they were injected into cutaneous lesions. And you can see here on the left side, these lesions are prominent, and 12 weeks later, both those lesions are gone through the bystander effect, revving up of the immune system, and the immune system taking care of the melanoma that's metastatic in other places. Another exciting intralesional type therapy is TVEC, or telimagene laherparepvec, or we'll just call it TVEC. So we were instrumental in the phase 3 trial that got this product approved back in October of 2015. It's an oncolytic herpes virus that carries the gene for GM-CSF, so it has a dual mechanism of action. One of the promising aspects of it is you inject it into the melanoma, and the oncolytic properties of the virus allows the melanoma cells to die. The GM-CSF revs up the immune system, so as those melanoma cells die, just like PV10, they release antigen. The local GM-CSF revs up the immune system picks up these antigens, hopefully creates antibodies, and then further creates systemic immune response. The phase 3 trial, its primary endpoint, which was a durable response rate. What's a durable response rate? It's a response that lasts 6 months or greater. So a partial or a complete response that lasts at least 6 months or greater. And you can see here, TVEC had a 16.3% durable response rate versus systemically administered subcutaneous GM-CSF of only 2.1%. Overall response rates were 26.4 versus 5.7%, and nearly 11% of the patients that had this local injection with this oncolytic herpes virus had a complete response of all their tumors. Here you can see a waterfall plot. What a waterfall plot shows us is the actual decrease in burden of or size of the tumor. So everybody starts at 0%. If you go above the line, that means your tumors are growing. If you go below the line, this is negative, that means your tumors are shrinking. So you can see here, there is a bunch of patients on the trial that had tumor shrinkage, very few patients on the GM-CSF arm that had tumor shrinkage, and obviously by the waterfall plot, it's not for everybody. Not every patient is going to respond. The duration of this response is a similar type plot, but it's called a swimmer's plot. In the swimmer's plot, it shows us how long the duration has lasted for the patient's response. The longer the line, the longer the response lasted. And if there's an arrow at the end of the line, that means the response is ongoing. Again, TVEC on this side and GM-CSF on the other side shows you just how much more powerful it was than the systemic therapy. 64% of the lesions that we actually injected responded to the TVEC. 15% of uninjected lesions, so we injected something on the left leg, but the patient had a lung lesion, just like I showed you with the PV10 slide before. 15% of those lesions actually responded to TVEC, so that's your bystander effect. And then 34% of the uninjected leg or subcutaneous metastases also responded. So there is a real bystander effect to this as well. We rev up the immune system, and as we know, melanoma is very immunogenic, so it revs up the immune system and you have a bystander effect. The trial had an improvement in overall survival, but it wasn't significant when you look at all comers, even though the lines separate there. However, we only use this drug now based on its FDA label, and it's used for patients with those in-transit type metastases or subcutaneous metastases. And you can see here there's a significant difference between survival for the patients that get TVEC versus GM-CSF when used for the right indications. We really don't use it for the patients who have distant lung, liver, and other type of disease. So in summary, and I'm going to talk a little bit about this later when we talk about what's new and exciting at Moffitt, regional therapies and intralesional injections are really strong therapeutic modalities for the treatment of in-transit metastases. Limb infusion and other intra-arterial therapies are definitely an option and efficacious for melanoma to the limb, and I'm going to talk about liver treatments later. Combination therapies with intralesional and some of these powerful systemic therapies might be the best way to really approach these patients. And we're still trying to figure out which one comes first. Do we start with regional therapies and then go to systemic for maintenance, or go maintenance and regional therapy at the same time? That's a focus of ongoing research at this time. Thank you guys for your attention. We'll be happy to answer any questions.